Good morning. I'm Zoe Mullan. I'm the editor-in-chief of the Lancet's new open access journal, the Lancet Global Health. And I'm really delighted to be here today at this meeting, and particularly introducing this panel, which I must say promises to be really quite unusual and stimulating, because our panelists are all from extremely different backgrounds. But I think it's shaping up to look like there are going to be some things that are similar between them. That's what we're hoping. But without further ado, I'll introduce that panel. So on your left is Christine Hancock, and she's sort of looking at the health angle for us this morning. She's executive director of an NGO, C3 Collaboration for Health, which looks at the impact of the environment on non-communicable diseases and women's health. Next up, we have Jayson Otke, and he's coming at the sort of technological angle, and he's the External Affairs Director of Philips Healthcare, UK and Ireland. And he's going to be looking at trends and opportunities, challenges in community-based healthcare innovation for women particularly. And finally, we have Dr. Barbara Penner. She's a senior lecturer in architectural history at the Bartlett School of Architecture at UCL. And Barbara tells us she fell into toilets by accident, which I don't think was literal, hopefully. So she's actually going to be talking about the really important issue of toilets in terms of access, design, and sustainability. So thank you for listening to me. I'm going to hand straight over to Christine.
Thank you. And I've been bold enough to have slides, so despite a great caution from Wiley about slides, but there it is. I'd like to say how really pleased I am, especially pleased to have the opportunity yet again to meet with Dr. Melish. Afaf and I had an exciting few days in Beirut, which is definitely a city with challenges for women and indeed for others. I'm also, like Ruth Carnell, I'd like to really welcome you to London. I'm a Londoner, completely born and bred. I live about 3 miles from here in a house I've lived in for 30 years, which is a mile from where I'm born. But I was very privileged, particularly during a 4-year period, when I had a global role, when I was able to travel widely. And my current organisation, as Zoe said, is a global NGO. And we're focused very much on the prevention of chronic diseases. There are, and many of you may know this, 3 key risk factors which cause the 4 major chronic diseases. Cardiovascular disease, so that's heart attacks and strokes, about which Ruth spoke so strongly. Diabetes, which she also discussed very strongly, and several of the cancers and chronic lung disease, which cause 50%, over 50%, it's probably 63% now, of deaths worldwide. And they are almost entirely due to 3 risk factors: tobacco, smoking, lack of physical activity, and an unhealthy diet, including harmful use of alcohol. And just a feel for how significant they are. The slide on the left, that greeny grey colour, is the chronic disease burden, non-communicable diseases. And over a 30-year period, the communicable diseases, all the things that used to have such impacts until relatively recently, even in our own countries, but particularly in developing countries, are now a much smaller part of the burden of disease worldwide. And 80% of the deaths that occur through non-communicable diseases, NCDs as they're known globally, are in developing countries. I used to think it was all about, and I realise it's a very dangerous thing to say in this audience, I used to think it was all about big fat Americans followed closely behind by big fat Europeans. Well, that is a problem, but it's nothing like the problem in countries like India, China, and increasingly in Africa, where people still have some of that burden of communicable disease, but where they're getting chronic disease, not just like we did, but much earlier, at a younger age than we did. NCDs disproportionately affect the poorest people in many societies. So here in London, as you go around, you'll be amazed and impressed at how well we've done in managing the tobacco and smoking. I rarely meet someone who smokes. I don't go anywhere where there's smoking because it's banned in restaurants, in all public places, in offices. And in this country, we have about an average of 20% of our population who smoke. But in the poorest parts of this country, almost half the people smoke. And in the richest, it's about 12%. So that fantastic difference, even in a country like ours, of the risk factors to poor people compared to the wealthier people. And many of these deaths, and probably more significant than death is the real burden of chronic disease. Chronic disease, diabetes, is the main cause in this country, and I guess in the US, of amputation, blindness, and renal failure. So the diseases themselves, and they're not, as I think sometimes the movies make us think, these are not about people who are having a great life and suddenly they keel over dead. And when the odd 10 years here or there doesn't really matter too much, one might think, but they're about really foul illnesses that debilitate, that cause pain, that cause suffering, and make life really, really difficult for people. And the thing that motivates me and motivates my colleagues, some of whom are here, to be involved in our work, is that they're preventable. That's what I couldn't believe, even with my long career in healthcare, that you could prevent 80% of heart disease and strokes and diabetes and almost half of cancer and practically all chronic respiratory illness just by doing such simple things as not smoking, eating less and better, and taking a bit more exercise. We, in this country, spend, and particularly in London, we agonise over expensive drugs, new hospitals to be built, old ones to close. We never, ever talk about walking or moving. We never talk about vegetables as opposed to red meat. And yet, they don't cost money. They don't cripple our health budgets like health budgets are being crippled all over the world. But there is growing recognition of this, and I give real credit, I think, to putting on the global agenda the World Economic Forum, who every year look at the seriousness of the risk and the likelihood of its happening. And they put, in 2010, they put chronic disease up there, above climate change. Only financial risk they had as a higher risk. Well, they would, wouldn't they? They're closer to it and they know more about it, I guess. So getting involved in changing policy is one of the things that we're about. And I'm really proud of the slide on the left. That's me and one of my colleagues at the UN, because the movement to recognise this happening led to a UN special meeting, only the second ever taken place on the subject of health, at the end of 2011. When the UN addressed and had 192 countries there, was the most boring meeting in the world because 192 countries all said exactly the same thing. This is a really terrible problem and we're struggling to deal with it and we don't really know how to do it. But it brought together an amazing group of people, and there were side events and meetings and publications associated with that were fantastic. But the slide on the right is probably more important. That's a bunch of women in a city in England looking at their environment to understand the problems of their environment in terms of the likelihood of it inhibiting some of those easy ways of living more healthily. So, for instance, quite close to where we're standing is a huge park, great park. It has no lighting. So in this country, in the winter, the end of the month, that it will be closed at 4 o'clock and you can't go into it. because it's not lit, there are all sorts of rumours that it's unsafe, that people get attacked, that it's dirty, and so people don't use it. Massive space, hardly used at all. There are 2 supermarkets quite close to each other, small ones, small shops, but the same company. The poorer end of the territory, you can't get fresh food. The other end, where the richer people are, there's good access to fresh food. So one of the things we've been doing, and we're working with colleagues in Connecticut who've devised a tool to scan the urban environment, the very detailed checklist. They developed that as a research tool in Mexico, China, India. They then used it in New Haven with young people using it themselves to lobby locally. And we've been using it here with their support to engage local communities, initially with a group of young people looking at sports facilities, but now in a very poor area of East London, as Ruth Carnell was talking about, to look at people looking at their environment so they understand and hopefully they develop the tools and the understanding to demand that their environment is healthier. Now, you've all been sitting down for a long while. I'd just like to ask a few of you to stand up. How many nurses, or people who think they used to be nurses, are there in the room? Oh, not as many as I thought, but quite a lot. No, I was about to. No, you stole... Dean, you stole that from me. I always used to say to people, there's no such thing as used to be a nurse. There are 19 million nurses in the world. So we in our work have really very little to do with the healthcare system because nobody goes to the health service until they've got these conditions. We're trying to prevent it. But one of the things we do know is that health professionals can have tremendous influence on people's behaviour. There was a wonderful piece of incredibly obvious research published from the US last year, what one of my colleagues calls research into the very obvious, where somebody surveyed several hundred physicians in the US and discovered, surprise, surprise, that fat doctors don't talk to fat patients about losing weight. I guess the same may be true among nurses, but there's much less research into nurses. So we have a large nursing program, which is working in 2 or 3 key areas. One is we're following a group of nursing students with a control group, so that if we can engage them in some of these issues before they start training, will that make a difference to their practice at the end of their training? We're doing some work with diaspora communities, again, as exists in the US, I know. In this country, there are nurses from other countries, many of whom have been here for years, but they maintain an association themselves, and they go back home, as they would call it, to talk, to work and to engage. We had an amazing meeting of such nurses, and they varied from the Nigerian nurses who had a memorandum of understanding with their government to the Sierra Leone nurses who said, we buy blood pressure machines on eBay, and when we go home we set up a trestle table in the marketplace and we take people's blood pressure and give them advice on what to do. And the nurses from the Caribbean who said, we don't have to take clean needles home anymore, the health service is better, but they see diabetes as inevitably leading to amputation. Amputation, if you have diabetes in the Caribbean, you lose your foot. So just very finally, on the environment, I hope while you're here, some of you may take a Boris bike named after the mayor, but just to point out to you that the last survey I saw showed significant 10 out of 13 deaths in London were to women, even though 3 times as many men cycle in London as women. So the environment can be an unsafe place, but it's a really important place for improving health. Thank you.
So first of all, I'd like to thank all of you and for the organizers for inviting me to join the panel discussion. I also have just 2 slides that I'd like to show. And what we discussed prior to today's meeting was how can we bring the sort of technological side to the discussion into today's meeting. And what I'd like to do is just spend a couple of moments talking about some of the technological trends that we see affecting healthcare and also as they relate to women's health more generally. Now I'm thinking, yes, there we are. I first wanted to just spend one moment quickly giving a snapshot of what Philips does in healthcare and in women's health specifically. I'm sure many of you are very familiar more with our consumer products and with our lighting, but actually we have quite a significant background and legacy in healthcare, specifically in medical imaging and in patient monitoring. And the disease areas that we're focusing on are very similar to the areas that Christine mentioned, being diabetes, cardiovascular disease, and cancer. And obviously, with respect to women's health issues, breast cancer would be one of the most significant cancers that are encountered. So our technologies are really looking at how to screen and identify diseases that go on inside the body, such as cancer and cardiovascular, but also technologies such as ultrasound and fetal monitoring. So at different stages of a woman's health, and technologies that are actually involved in very many common experiences that women have in a healthcare system to do with pregnancy, delivery, and so forth. And in the areas of monitoring, these technologies would extend into areas such as neonatal and pediatric intensive care, as well as those products that support moms after delivery, for example. We really stand behind the motto, breast is best, and our products are really focusing on helping give women the greatest number of opportunities to support them, for example, in breastfeeding. So that's a quick just run through an overview of the areas that we're involved as Philips in women's health. The other area, there we are. These are the technology trends that we see in healthcare generally that I just wanted to spend a little bit more time discussing. In the medical technology field, there are really two areas traditionally that have been extremely important when developing new innovations in healthcare. Obviously, the clinical efficacy that the technology works and helps, and secondly, that there is a benefit to the patient. But more recently, over the past 10 or 15 or 20 years, the efficiency and the healthcare economics come increasingly into play. And what I mean by that is how can the technology address clinical needs, patient benefit, but also help healthcare systems that are grappling with limited resources, but an ongoing rise in demand for healthcare. And what we're seeing is that while there are these challenges, there are some developments in technology that help enable different approaches to care that can help circumnavigate some of the bottlenecks on demand. For example, the motto of earlier and preventative is usually less invasive and more of a benefit to the patient, and it's usually also more efficient and cost effective. So if you're looking at minimally invasive surgeries that are enabled through early diagnosis of tumors or circulatory problems, it's easier and more effective if you can identify those earlier on. Another area where technology has the potential to help is in enabling the sharing of patient information across very big healthcare systems. So this isn't a solution for everything because technology will only help organizations that are also working in a structured and linked up way. So there is, for example, in a healthcare system like in the United Kingdom, where you have a single payer system like the NHS, there's a great potential for using technology to share patient data at different stages of a woman's experience when she's going to the GP or into a hospital setting or back out into the community. It does mean that the organizational structures of health and social care need to be set up such that the data is something that parts of an organization want to and can share. There is the trend that we're seeing increasingly of also shifting care into settings where, frankly, patients prefer to be, which is not in a hospital, but to be able to maintain their independence as long as possible in home. We're seeing this increasingly as chronic disease becomes more prevalent, in particular as populations age. But this also allows people to maintain their health and also do it a bit more cost effectively. And we're seeing in the United Kingdom, again, a lot of interest by the government and the NHS to see and explore how more chronic disease management can be done in a home setting. And finally, the points that Christine raised, the most cost-effective way of managing healthcare is not getting sick in the first place. So prevention, wellness, and providing the means for people to stay healthy, stay fit, maintain their nutrition, such that they don't find that they end up being sick. So if we look at these trends in say, a setting related to women's health, one example from Philips that comes to mind is in the area of breast cancer screening, which is the most common cause of cancer in women. It accounts for between a fifth and a quarter of all cancers that women would encounter. In Europe, starting in Scandinavia, but also soon thereafter in the United Kingdom, government-funded universal breast screening has been introduced, and it was based on a mixture of the clinical efficacy, the benefit to the patient, and ultimately driving this, the healthcare economics, that if you can screen and reach women in the community at an early stage, you can have the potential of identifying and treating where needed most effectively. Naturally, that poses challenges for technology companies like ours. Obviously, the one that's fairly familiar is early screening and false positives that can be identified, which leads to unnecessary treatment. And this is something that research into medical imaging is really focusing on today, on how to eliminate these occurrences of false positives. The other challenge is simply how do you move medical equipment into a community setting? Some of these, if you're looking at breast cancer screening, you're looking at X-ray mammography, which is rather heavy equipment. So it has to be mobile, it has to be stable, it has to be accurate. So in terms of the product development and the technology, these are some of the issues that we're looking at to enable more of that accessibility in a community setting. There is, and again, it's the healthcare economics that comes into play. Medical scans for breast cancer take a certain amount of time depending on the technology. So, for example, the most accurate scan would be magnetic resonance, which would take perhaps 30 minutes. Standard scan using X-ray mammography will take 5 minutes, which enables you to perform many more scans in a community setting. So you're always weighing the amount of provision of services in a community against the latest developments in technology and how can you optimize those mixes. And that's where much of our research is looking at how to optimize efficiency of time for scanning and accuracy. And then I think the last issue, touching also on some of the points that Christine raised, are also behavioral. If you're looking at prevention and a focus on prevention, there's always the challenge of reaching people, women in this case, to make them aware of the benefit of prevention simply because of the challenge that when people don't feel sick, they often don't think about prevention because they have other challenges on their day-to-day schedule and on their time. So looking at the place and the location for prevention and for diagnosis can make a big difference for one. So studies have shown that people who are not sick prefer to be treated in or have the opportunity for screening in a community setting in locations such as sports centers, shopping centers, and these sorts of locations that are not directly associated with illness and disease when this is something that the individual doesn't identify with at that stage. There's also the challenge increasingly of, if you look at those last 2 points of moving care into a community setting and focus on prevention, essentially what you're doing is you're now putting the layperson more in the driver's seat of managing their own health. Now, if people get to a stage where they have a disease that needs addressing and treatment, be it breast cancer or chronic diseases that can be handled in community settings, you then have to look at the issue of adherence to ensure that people that are not healthcare professionals have the information and the motivation to ensure that they are carrying through their regimen in the appropriate way in a setting that they're familiar with. So there is the psychological issues that need to be addressed. Not all patients are the same, not all women are the same. So they have different informational needs and different motivators that trigger them to respond and manage their treatment in different ways. And if we're developing technology that needs to be increasingly used by the layperson, then we really need to understand how these people interact with it and how they're motivated by it. So education, location, and also motivation become key factors for us. With that, I'd like to end with a tiny little clip of an interesting way that we've been looking at Philips, working with our design colleagues and the advances we're seeing in basic phone app technology to see how in an innovative setting you can motivate a patient to manage their health more effectively, hopefully. This particular video clip that I'd like to show, it's a part of a video, approximately a minute and a half, shows a woman who is in labor and is receiving coaching to breathe in the appropriate way to facilitate the labor that she's going through. So with that, if possible, I'd like to show the little clip.
Drawing on Philips' expertise in healthcare, ambient experience design, data visualization, and digital connectivity, the concept has been developed in close collaboration with mothers, their partners, the Maximum Medical Centre Veldhoven, and the Eindhoven University of Technology. An expectant mother is introduced to the breathing coach app in the later stages of pregnancy. In the preparation for the birth, the app helps her to practice labour breathing techniques and set them up in a way that feels good for her. The expecting couple can also use the app to personalise the delivery room environment by choosing their preferred theme and colours using the smartphone app. Once the woman and her partner enter the delivery room, the environment syncs with the settings on the phone, creating one connected system. The room is personalised in the way it was planned. Using data visualisation, the interactive animation projected on the wall of the room grows and changes in response to the progress of the birth. The animation is based on contraction monitoring data and assessments made by the obstetrician. When a contraction starts, the animation on the wall switches to the breathing coach to support coping with contractions. It also offers a point of focus, something to hold on to. Besides that, it can help the partner to support his wife. After each contraction, another flower grows on the branch, raising the leaf. The size of the flower represents the duration of the contraction. The colour intensity represents the intensity of the contraction, and the distance between flowers a woman and her partner a simple and attractive impression of progress, and also provides welcome distraction in between contractions. The animation flourishes to celebrate and intensify.
So you get the idea. This isn't available, but it is an interesting, quirky way to see how technology potentially can be using the sensors that you have on a simple phone app integrated with other monitoring devices. So with that, I'd like to hand it over to the other panelist. Thank you.
Thank you. Good morning, everyone. And I'd also just like to add my thanks to that of the other panelists, to Penn, for this conference and this opportunity to speak. So today I'd like to talk to you about toilets, a topic that is still considered unmentionable and perhaps too mundane to discuss and raise at academic conferences like these. My aim today is to make the case for why toilets are actually incredibly relevant to discussions of gender, health, and urbanism, and also to argue that toilets are just as relevant to developing so-called developed world cities like London as they are to developing world cities. So I should start off by acknowledging that toilets are not nearly as invisible in public discourse as they were just a decade ago. One reason for their new visibility is the United Nations Millennium Development Goals, which set the target of having the number of people without basic sanitation, currently estimated at 2.6 billion people, by 2015. This goal still looks very far away. Indeed, it's said to be the most off track of all of the MDGs, largely because sanitation has always been the unloved and underfunded cause in comparison to its much sexier and cleaner companion, water. Nonetheless, the sanitation field has lately been energized by the arrival of important new champions, from the World Toilet Organization to, yes, it exists, the WTO, and the Bill and Melinda Gates Foundation, which very ambitiously set itself the target of reinventing the toilet. So the reason for the interest in sanitation is obvious. Every day, thousands of children under 5 continue to die due to fecally transmitted diseases, deaths that improved sanitation could do much to prevent. Sanitation is also much more cost-effective than many other forms of intervention, which is why toilets are very often referred to by NGOs as the cheapest vaccine or the cheapest medicine. Every dollar invested is said to return $3 to $34 in terms of improved health and improved productivity. But apart from these arguments, other justifications are emerging as well that emphasize the environmental and also the social benefits of toilets. And I think what's interesting and relevant to think about today is the fact that study after study shows that few social groups benefit more from improved sanitation than women. There are many explanations for why clean, secure toilet facilities create better societies for women, but in the interests of time, I'll sum up the main ones. First, clean, safe toilets ensure better female health. Not going to the bathroom when you need to go can create medical problems like urinary tract infections, causing lost days at work or at school. Second, clean, safe toilets reduce female labor, as it's usually women who carry water for personal cleansing, along with other household needs. Third, clean, safe toilets limit exposure to sexual violence. When women, particularly in slum areas, travel long distances to find a toilet or defecate in the open, and they usually do this at night, they're very vulnerable to sexual assault and to harassment. Fourth, clean, safe school toilets greatly increase the chance of young women staying in education after puberty and after the onset of menstruation. So, in other words, the provision of toilets positively contributes to female health, safety, and importantly, I would say, dignity in the global South in many different ways. This recent realization, in turn, has helped secure much stronger support for toilets in international development circles. So this year, the UN has finally declared 19th of November to be World Toilet Day. So please put that date in your calendars and help us celebrate. What fascinates me, however, about this discussion about global sanitation is that it focuses almost exclusively about what is happening out there in Southeast Asia, in India, or in Africa. What about our own situation here in the global North? Of course, we are blessed with almost universal sewer coverage, and most of us will never know the indignities of open defecation. But that doesn't mean that we can afford to be complacent about toilets, particularly if we're women. Toilets are important for women here for the same reason that they're important for women in the developing world. The lack of clean, safe, what's called away-from-home toilets negatively affects female health and mobility. While women especially need this kind of access when they're unwell, if they suffer from gastrointestinal, reproductive, or urological problems, for instance, but healthy women need them too, especially when pregnant or menstruating, or when they're caring for young children. Now, to me, these do not seem to be surprising or controversial points to make. Yet overall, our cultural views towards toilets in the UK might still be characterized as ambivalent, even schizophrenic. On the one hand, we clearly do value toilets on one level. Victorian London's pioneering sewer system continues to be recognized as a great national achievement, and in our homes, bathrooms are larger and more lavish than ever. Yet the trend towards private comfort contrasts sharply with the general condition of public facilities. 50% of UK public toilets have been closed since 1995. Many of those that remain have been privatized and now charge fees. So here in Westminster, where this conference is taking place, most public toilets now cost 50p, and they're run by a private contractor called City Loos. It constantly surprises me that there's not more public awareness or at least concern about these developments, as they obviously affect the quality of our street life and of our urban experience, particularly if we're women. So this is ultimately, to my mind, why it's important that sewers or no, we shouldn't exempt cities in the global north from current debates about sanitation. It's only by looking at sanitation cross-culturally that we may come to consider our own situation far more critically than we have done up till now. Our attitude really is still very much flush and forget. Most people just can't be bothered. Surveying the sanitation field globally will remind us, I think, that it is incredibly short-sighted to take toilets for granted. Far from being too trivial to discuss, we should recognize that toilets need to be fully integrated into efforts to create age-friendly, accessible, and gender-friendly cities that support and encourage the kind of healthy behaviors that Christine was mentioning in her talk at the beginning. So thank you.
Okay, that was an interesting couple of talks, I think you'll agree. So I just have a few questions that I'd like to fire off to our panelists now before we open up to the floor. So I might kick off with Jayson, actually. We've talked a lot here about prevention. Prevention seems to be the key in all these speeches we've heard here. And prevention quite often means behaviour change, especially when it comes to non-communicable diseases. So from a technological point of view, do you think design can change behaviour, or is something else required?
I think design is one factor that can contribute to behavior change. As I mentioned when I was speaking a little earlier, I think the first thing that one needs to realize is that people are different and they're motivated in different ways. And one of the studies that we carried out last year, our design colleagues, was to understand and see if we could identify what we call phenotypes of patients or individuals in terms of how they interact with technology. And interestingly, in an initial qualitative study that we carried out, we found that about 75% of patients would fall into roughly 4 categories of behavior and interaction with technology, depending, for example, on socioeconomic and other issues. So I think that's a first step in understanding, okay, what is a motivator? I think all of us as consumers will make our decisions around what we buy in terms of technology and other things based also on design, on very subjective things that sometimes we may not even consider. And this is an important factor to take into account, in particular as you start to see technology appearing in home. For example, we trialed here in the UK home clinical monitoring technology that helps chemotherapy patients in home monitor their temperature. Temperature is an early indicator of an infection if your immune system is suppressed. Again, the device looks almost like an iPad or an iPod docking station. It's very inconspicuous and designed in a way to not look clinical, not look off-putting. So we found that there's greater engagement and an ability toward adherence in monitoring your temperature if you do it in a way that's pleasant in a design perspective.
Thank you. Christine, what do you think are London's biggest areas of opportunity for preventive interventions, and how can working with women help make a difference in these areas?
I'm not sure that London has that many opportunities that are very different from other cities. And clearly working with women would engage half the population straight off. I think that we're talking more about active transport, active movement around London, but we're way behind other cities, and we learn a lot, I think, from, you know, take the bike example, which I gave. Paris, Brussels were there, Copenhagen, Amsterdam, long while before us. We've been very, very slow to recognise that just putting bikes on the streets is pretty dangerous, and painting lines on the streets doesn't make it that much better, and we've very, very few places where it's safe to cycle. We've not done as much as you walk around New York. I don't know what inspires it, but there are fresh fruit sellers everywhere. Much harder. London's a lot better than the rest of England. We have more small local shops, even in poor areas, selling fresh fruit and vegetables than in many other cities in England, but it's still not as good as many others. So, as usual, I think, we in England probably got more to learn from other countries, but we're not terribly good at doing that. The great opportunity we have, I think, is some of what Ruth said, which is fantastic, inappropriate investment in health facilities that we could really transform. So, one of the programs that we're engaged in is actually working with health professionals about understanding some of these things. There's no, as far as I know, there's no medical curriculum that includes the evidence around physical activity, let alone how to get people physically active, even people who are in front of you in your practice. So there's lots that we could do, and we have lots of assets that can work on. But I'm not really convinced on the prevention front that we're very far ahead of others. And New York, I think, particularly around food labelling, around its attack on inappropriate portion size, is leading London rather than the other way around.
Yeah, I think you're right. And finally, Barbara, maybe you could add something to that. Maybe there are some other countries around the world, because you work in quite a global field with the toilet. Do you think London and developed countries can learn anything from other countries around the world that maybe aren't so developed?
Sorry. I've been thinking a lot about this. I think that the issues are so very different when you're talking about the developing world versus the developed world. And in the developing world, at the moment, one of the main debates around sanitation is how do you create demand for sanitation. So if you have a community which has been accustomed to open defecation, how do you then convince people to change their habits? It's not, the current thinking is that it's not enough to provide a toilet. People have to want to use that toilet. And so one of the main debates at the moment in those settings is how do you create that demand? And different communities, different organizations have different answers to that question. But partially, people still place great value on education. People also are now talking much more about aspiration, turning the toilet into a status symbol so that it's something that people want to have in their homes. And then finally, also mobilizing shame about open defecation practices through, some of you may have heard of community-led total sanitation, CLTS, and that tries to harness people's sense of shame and embarrassment about open sanitation to get them, trigger them to do something about it. So we don't have those same kind of problems. Most of us are quite used to having a toilet in our daily routine and would find it quite odd not to have a toilet in our daily routine. In our case and in our context, I think it's just merely trying to overcome societal taboos and also challenge existing social values, which sees spaces like toilets as unimportant, rather than seeing the different ways in which they can contribute to a healthy and positive urban environment.
Well, thanks very much to the panel for answering those questions. So now it's up to you guys. Can I have some hands for some questions? And we'll bring a mic around.
I just wanted to say, while we're on the subject of societal taboos and unmentionables, it's just something that I always rant about with my friends, about how it seems as if our sanitary provisions, our public ones in London, seem kind of unfairly distributed. For example, it's so easy, if you want to get free condoms, but women aren't given free sanitary supplies. And the amount of money that a woman will have to spend in her lifetime, I mean, obviously, not her whole life, but there'll be a significant fund that's just devoted to that. And it's strange, and also just advertising of those kinds of things as well is so much based on hiding yourself away. And yeah, I was just wondering if we could talk about that.
No, I think that's a very important point. And I also think that there's many inequities in provision. So, of course, any woman who's been to the theatre in London recently can attest to the fact that there are still significantly more facilities for men than there are for women. And that's due to many factors. Perhaps one positive contribution, so that we don't dwell too much on the negative, is that in many countries they're now beginning to pass what are called potty parity laws, which ensure that double, or in some cases 3 times, as much provision is provided for women as it is for men. And in most public buildings, for instance. And that's been important, I think, because it's actually brought some of these issues, the gendered nature of toilet provision has actually become a subject of debate as various governments have considered passing these laws. So I think things like that are quite important to raising visibility, but we have a very long way to go. And even the international community has only just started to talk about the issue of the disposal of female sanitary products, for instance, in public facilities. So a long way to go, but it is happening.
Good morning or good afternoon. Jackie Bolton, King's College London. An observation mainly on Barbara's point, but it crosses across everything really we've discussed. I was in Sierra Leone recently, and I was looking around a fistula clinic and a new maternity clinic. And it was all very, very impressive, but all completely different to most of the health facilities that the population were used to, because it was all new and white and clean. And of course, the question is always, you can take a horse to water, but you may not make it drink. And so, you know, any facilities or any interventions we do, and it touches on my colleague over there, saying must be relevant to the population for whom they're intended. And one of the things that happened that was quite impressive in this new facility is that they have several sets of toilets. They have flushing toilets and they have hole toilets. And I think it's really important because many patients are coming down from rural areas, and it's completely new to them and quite frightening as it is. And so they have the choice and the possibility of experiencing a different type of toilet, if you like. So I just wanted to say that the importance of kind of whatever we do being relevant.
I just wanted to follow up on the discussion of technology in the provision of health. And I think you raised some really important issues around how consumer goods can help patients and manage their health better by taking ownership in understanding their disease and managing their disease. And correct me if I'm wrong, my understanding is that you may have a self-selection bias in which people who are more likely to be concerned about their health and more likely to be healthy will be using these technologies. And I was wondering if, going back to the issue of creating demand, what approaches you can take to make sure that people who perhaps lack the education or the resources to know that these technologies are out there, and making sure that they're able to create that demand. Thank you.
That's a very good point, and I think what I perhaps failed to mention more clearly is there's quite a clear distinction between purely consumer products that are obviously based on an individual's decision whether they'd like to buy them, or whether one is using a certified and regulated healthcare device in a home setting. So that patient wouldn't be opting to use a monitor and supported by a service that provides remote information, supported by a call center with healthcare professionals. That would be based on an assessment by a healthcare specialist who would say, okay, let's prioritize those patients that meet various criteria that stand to benefit the best due to the stage of their disease to be monitored and managed in a home setting. So while that could apply to certain consumer products, generally for the main healthcare products for treating chronic disease management, for instance, would be based on prescription.
I'm Mary Archer. I chair Imperial College Health Partners Expert Advisory Board. Jayson, a comment for you. First of all, I loved the Labour movie. I'd love to have it playing when I'm doing the washing up or the ironing.
I heard a lot of laughing. I wasn't sure if that was...
You commented that false positives in breast cancer screening are a problem. I think there is a bigger problem with breast cancer screening. I was a member of King's Health Partners expert panel that advised the Informed Choice About Cancer screening program, which has recently been chaired by Mike Richards, who has now gone to be Chief Inspector of Hospitals. We looked at colon screening and cervix screening as well as breast screening. But the statistics, as you will know, I think, for breast screening are quite controversial. For every death from breast cancer prevented by breast screening, 3 women are diagnosed with and treated for breast cancers that are indolent and would never have caused them a problem in their lifetimes. And of course, treatments for breast cancer, particularly chemotherapy, are extremely grueling for women. So I think the root cause we need to advance the knowledge of breast tumors, and it's very good that genomics, reading genes, is becoming so much cheaper. So it's now known that breast cancer is effectively 10 distinct subtypes genetically. And that will bring in stratified medicine so that women will get cocktails of drugs that more accurately target their particular tumors. So I think that screening technology can go so far, but it has to go hand in hand with advances in molecular diagnostics.
As I indicated, there is, I don't come from a medical background, but having worked with Philips for a while, you learn very quickly about all of the different types of developments, even in the past 20 years in medical imaging and the interplay between different types of scanning technologies, I think it's incumbent upon organizations like ours to ensure that we're doing research that doesn't lead to unnecessary treatment, because that is obviously not ultimately the goal that research and development would want to achieve. But I am aware of molecular diagnostics, and I think it offers a very interesting potential.
Hello, my name's Rachel Flowers. I'm a public health specialist working as part of Helen Walter's team for the JLA. Actually, this is really a call on the back of Ruth Cornell's Coalition of the Willing to say, could people search out for me afterwards if they're interested around the issue of urban spaces, healthy places for London. I have to point out that I was a director of public health for Newham before, and previously an environmental health officer, the first environmental health officer in the country, London employed, and toilets are a particular issue. For those of us who've ever searched for a toilet anywhere in this city around there, there are lots of dynamics around water and sanitation within this country as well as other parts of the world. I'd also be happy to discuss that too.
Okay, on that note, I think we will finish for lunch. Thank you very much for listening, and thank you to our panel for giving us these really stimulating talks. Thank you.